I'm pulling the nerve down. What we want to do to keep a nerve mobile against its surroundings is flossing, alternately pulling it up and down. So we'll get the person to pull the nerve from below, then pull the nerve from above, then pull the nerve from below, then pull the nerve from above, and not pull it in both directions at once, which doesn't move it, it just pulls it. Now, just stretching the sciatic nerve will, if you do it enough, encourage the nerve to grow longer. So if you need to lengthen your sciatic nerve, then you need to pull it from both directions and do it chronically for a long time, every day for years, or months, anyway. And the nerve will grow longer. The goal here isn't to get the nerve to grow longer, it's to keep it moving relative to the hamstring, so we floss it. We do what's called nerve flossing, okay? Other questions? All right, so we want to cover off some hip joint disorders. We're now talking about the femoroacetabular or coxofemoral joint, whatever you want to call it. Hip is fine. The hip can be considered a region of the body, but we can also correctly use that word just to refer to the coxofemoral articulation. Hip joint disorders, there are all kinds of problems. The things I want you to understand are these four. And I'm going to talk a little bit about some other stuff, but not really, okay? So, KP 363, we're going to talk about four different hip problems. Joint surface degeneration, labral tears, femoroacetabular impingement, and scuffies. That's the nickname for that, scuffy. Okay? Call them scuffies, FAI, labral tears, and this would be called osteoarthritis or osteoarthritis, OA. They are all four different phases of the same problem in most cases. Okay? These four things are related to each other. And what I'd really like you to understand is the biomechanics of the coxofemoral articulation and how and why these four problems are related to each other. That's what I will be asking you on the exam. To explain the sequence of pathology, how as a young person you have this as a 13-year-old, and then you have this when you're 19 or 20, and then you have this, and then you get this. And I don't know, some of you may or may not know, it's in the newspaper today, so I'm not giving away any secrets that aren't public. But Michelle Lee, bronze medalist in badminton at the Beijing Olympics, she's a KPE student. She actually left school to concentrate on her Olympic badminton. She played again in London and Rio. I think she's been 3 times. But she didn't do well in Rio, and then later confessed to the public because she had multiple injuries that she hadn't taken care of. She underwent hip surgery for this and this. I mean, she's probably gone in that sequence. She's up to there at the tender age of 24 or whatever. Anyway, there's life after labral tearing. She had a labral repair. She wants to go to Tokyo and win another medal, and we wish her great luck. This is common stuff. And a lot of you have at least this. We think probably about 10-15% of the population has FAI. And FAI is the recipe for osteoarthritis of the hip. We can take all the people that get arthritis of the hip in their life, which is everyone if you live long enough, right? If you're 120, you've got OA of your hip, pretty much guaranteed. But if you take the population at different ages, at 30, 40, 50, 60, 70, 80 years old, and you do studies and say, what percentage of the population has osteoarthritis of the hip? Well, by the time you get to 110, you're well up over 90%. At 78 years of age, probably 60, 70% of the population shows some evidence of hip degeneration. But at 40 years of age, there's like 15% of the population that has what we always used to call premature. We still do, premature OA of the hip. It's considered premature. Why does a 40-year-old have OA of the hip? It wasn't figured out until the mid-90s. Whoops. What am I doing? This problem was named in 1995. This problem was named in like 1900. But we didn't put it together. People didn't understand the relationship between this problem that is an acute injury of a 13-year-old and premature osteoarthritis of the hip at age 40. And now we realize that probably just about everybody who has arthritis of the hip by the time they're 40 had FAI as a teenager, and probably not all of them, but a majority of them had FAI because they had a scuff. So I'm going to explain the biomechanics of this cascade, if you like, this sequence of pathologies, and I want you to understand it. Because please, for yourselves, if you have FAI, you need to recognize it. And if you are a personal trainer or a physical educator or a coach or a teammate of somebody else who has FAI, you'll do them a favor to recognize it. Because we believe that if you recognize FAI early and change your behaviors, you prevent this sequelum or sequelae of FAI, which is labral tearing and osteoarthrosis. So we want to catch it. We'd like to catch it every time there. This diagnosis gets missed all the time. And there's sort of renewed emphasis on emergency department doctors sharpening their skills and not missing scuffies. Because a lot of teenagers have been sent home with scuffies over the years and not gotten treated, and then they get FAI, and then they get labral tearing, and then they get OA. So to recognize who has these problems, you need to understand how hip joint disorders manifest themselves. So you can recognize it in yourself, or in your teammate, or friend, or partner, or athlete if you're a coach, or a personal trainer, a client. The most important thing is the distribution of pain. The hip joint is innervated by 3 nerves, obturator, femoral, and sciatic. But most of the pathology in the hip occurs anteromedially, in this part of the hip. Almost all of these issues that we're talking about, we're not talking about disorders of the joint back here. If you had arthritis of the hip at the back, the pain would radiate down the back of the leg in the distribution of the sciatic nerve. Very rare. Almost all hip pathology is anteromedial and radiates along the distribution of the obturator nerve down the adductor muscles of the thigh. So most hip pain is felt at the inguinal ligament and radiating distally along the adductors. And a large number of people who have groin pain, who think they strained their groin, quotes unquote, whatever a groin is, you don't strain something that doesn't exist. The groin is a region of the body. So a groin strain, if it's a strain of something. Is it adductor longus, brevis, pectineus? What the heck is it, right? Most people have not strained a muscle in their groin. Many people with groin pain have hip joint disorders. Now, if it's more on the superolateral part of the joint, the pain will radiate down the outside of the thigh along the femoral nerve distribution, and if it's posterior, it will go sciatic. But those are a minority. So a majority of hip joint pain is felt along the adductor or obturator nerve distribution. And the classic question on every exam in orthopedics and medicine is on my final exam, my licensing exam in medicine. They put it on every exam, and still doctors miss it. Is a 13-year-old boy who's slightly chubby. They always have the chubby prepubescent boy as the subject because that's the stereotype. Shows up at the emergency department with medial knee pain. And the stupid doctor, I shouldn't say stupid, the doctor who's not doing their job examines the knee, doesn't find anything wrong, and sends the kid home. The kid does not have a knee problem. He's got a scuffy. Because a slipped capital femoral epiphysis presents as medial knee pain. This is understanding the mysteries of how pain is distributed and referred around the body is one of the hardest but most important parts of becoming a clinician if you want to be a clinician. You have to recognize patterns of pain referral. And hip joint pain refers this way and as far as the knee. And if you have a big problem, the worse it gets, the farther it goes. So when the kid has an acute high-grade scuffy, they show up with medial knee pain. And if the doctor examined their hip, it would jump up and slap them in the face, because as soon as they move the hip, the kid will scream. If all they do is examine the knee, they'll miss it. Other manifestations of hip joint disorders are snapping, clicking, giving away, or instability in the hip where it won't hold you up. Weakness, the leg feels heavy, weak, dead. There may be spasm, and there will be restricted movement. So that kid with the scuffy, if the doctor tried to flex a duct and internally rotate them, the kid would scream. They have a restriction of fadir, flexion, adduction, internal rotation. That movement, let's look at the hip joint for a second. This particular cadaver is very flexible. because it has no ligaments and no muscles, so nothing to restrict movement except for bones. This is a bone model only. If I only had bones and I have a normally shaped hip, look at that, holy shit, I can go 360, okay? Talk about ballet, watch out, Baryshnikov, here I come. But people, dancers who can actually flex their hip 180 degrees and stand there with their legs beside themselves, I will not attempt to demonstrate that and further embarrass myself. You know, they can do that, and their hip joint capsule permits it, the ligaments and the muscles are all long enough to allow the bones to do their thing, okay? But you notice that even, the question, if we ask, and here's another general principle that I want to remind you of, the range of motion of any 3-degree of freedom joint in any given degree of freedom is a function of the position of the joints in the other degrees of freedom. So the extent to which I can flex my hip depends on the position of my hip with respect to internal, external rotation, abduction, adduction. Because if I was abducted, well, now I can't flex my hip 180 degrees, can I? Because the bones are going to bump into each other. And in this position, I can adduct 45 degrees, but if I'm flexed, if I'm super flexed, if I was like the ballerina, I'd have 0 adduction. Because once I get up into that position, now the bones hit each other. So the range of adduction that is possible is a function of the extent of flexion. What usually constrains fadir, the combination of flexion, adduction, and internal rotation of the hip, okay? That motion. Anytime I try to bring this knee up to that shoulder and I have it internally rotated, we're going to call that flexion, adduction, internal rotation. That is the recipe for jamming the bones against each other. Because even in a normal hip, if I flex, adduct, and internally rotate, what stops the movement is the bones hitting each other, not the muscles. We get what we call impingement, femoroacetabular impingement, where the femur pushes against the acetabulum. Now, most of us only get femoroacetabular impingement at 90 degrees of flexion, 30 degrees of adduction, and 45 degrees of internal rotation. That's normal. In most of us, frankly, if someone does that and they think they're stretching, and they take their leg, and they flex, and they adduct, and they internally rotate, you're not stretching a damn thing. Ask yourself the next time you're in that position, where do I feel that? And if I push it, whoops, I'm going to push myself up. If I push it harder, do I feel it stretching in my butt? No, I don't. I feel it pinching in my groin. Because what is stopping that movement is the bones crushing each other. Worse than that, actually in between the bones, there are 2 layers of cartilage, joint surface cartilage and the labrum of the hip. So what gets damaged when you do that is the labrum. And that's how we're going to get labral tears from repeated femoroacetabular impingement. Okay? That movement, when people do that and they think they're stretching, I mean, I honestly want to talk to the person who feels that in their butt, not their groin. That's not the way humans are built. What limits the combination of flexion, adduction, and internal rotation is the femoral neck being jammed in against the antero-superior rim of the acetabulum. Okay? And I talked about this in first year too a bit, just that in general, as a general principle, you need to be aware of whether a particular joint movement is being constrained by tension in a structure that's being lengthened or compression, i.e. impingement. And movement that is constrained by impingement is not movement that you should push harder. You're not going to increase your range of motion, you're going to damage tissue. You're not stretching, you're hurting. Don't do it. So when I said earlier that I want you to be able to recognize scuffies and FAI and labral tears, what I want you to do is be able to tell people, don't do that. What are you doing that for? Oh, I got a groin strain, man, I'm going to stretch it out right there. No, you're not, okay? You're hurting yourself. Stop, please stop. And in general, as a stretch, like of all the positions that people put their body in when they think they're doing stretches, these stretches that involve flexion, adduction, and internal rotation of the hip, it hurts me to watch. It's like, why are we doing this? Why is this part of this exercise class? So, I mean, I told you can fracture your greater trochanter landing on your hip, and my buddy did his, and you can fracture your pelvis, and I know I micro-fractured mine. So landing hard on your side, aside from getting these soft tissue hip pointers, you can cause significant bone and cartilage injury.